Okay, so this is a 6-year follow-up then of 3 millimeter one-piece implants in areas of limited tooth-to-tooth spacing. And the outcomes we looked at were implant survival, bone loss, and we did that by standardized radiographs at baseline 6, 12 months, and then followed them up at 5 years. Changes in interdental papillae using the Yempt index, and we published the first year part of that a few years ago, the basis of the first year's data. So what we did was we used implants that were 12, 15, or 18 millimeters in length, okay, and then that had an 8 millimeter abutment. And I want you to pay particular attention to this transition zone here. This is an area of machined metal that is anodized in the top part, the gold colored part, and is the titanium, more of a silver color, at the bottom half of that. Now this is a relatively simple implant placement. You know, the drilling sequence itself includes 3 drills and a bone tap. And so that you prepare it using a starter drill, moving then to a 2 millimeter drill, and then a 2.5, which would be the finishing drill, and then a tap. But in the majority of cases, I often go ahead and work from identifying the position with the starter drill, doing a 2 millimeter drill, and then going directly to placing the implant. So this becomes, if you will, a 2-step implant. So that becomes a very quick implant to place and a useful option. Okay, the depth drills themselves, the 2 millimeters have stops in them, and this is helpful for flapless surgery, so that the implant has this little collar. The drill has this little stop on it, on a collar on it, that stops at the crest of the bone. So you know that if you bring this to the hub, that's for 12 millimeters. This line is 12, that's 15, 12, 15, 18, and so on. So it corresponds to the length of the implant, and those are somewhat helpful. Now the finishing drill simply takes the 2 millimeter osteotomy and widens it out to 2.5. So it's used to increase the width of the osteotomy only. And in general, if you're working in relatively dense bone, D1 or D2 bone, you'd go ahead and use the 2.5 millimeter drill. However, if you're working in softer bone, D3 or D4 type bone, you'd go ahead and skip that drill. So often if it's a maxillary lateral incisor in a young adult post-orthodontically, I would go ahead and go directly from the 2 millimeter drill directly to placing the implant, because you're really only going from 2 millimeters to 3, so you're only going a millimeter. And of course, with a narrower diameter implant, you can increase the torque, and going ahead and inserting it. So you pick up the implant from the vial, and it's very easy to do that with an adapter, and it has the actual width of the adapter that picks it up is 3.7. That's important because some of these narrow tooth-to-tooth spaces, we need to be able to make sure that we can go ahead and get that implant in. There's a few different ways you can place it. Generally, I like to place it with the handpiece itself. You can also go ahead and sometimes I'll use a ratchet. I rarely will place one by hand, but it's important to go ahead and place them at less than 30 RPMs, and to go ahead and place them in this transition zone, the space between the anodized gold-colored abutment and before the threads. Okay, so let's go through a patient. Here's a site that a patient has approximately, if you will, 4.5 millimeters of space. They've been treated post-orthodontically, and yet now they have this congenitally missing lateral incisor that we need to consider replacing. The patient has a bonded bridge in place after orthodontic treatment that we need to remove. We can see that there's a little bit of a insufficiency of bone on the facial, and there's also a little inconsistency of the gingival margin, and this is what we have to work with. So there's very little options for this patient. At this point, it's either to use a narrow diameter implant or to go back through orthodontics and try to open up that space. Here's a surgical guide that we made. It's simply made from a thermal foil and then filled with acrylic, and we've created a space in this where we want to go ahead and place our pilot drill with clearance for the 2 millimeter implant. So this is based on a wax up. Initially, you can see that between the central incisors on this patient, there's a gingival discrepancy. We did if you will, an inverse bevel incision and just went ahead and corrected that first, removing that almost as a gingivectomy, that collar of tissue, and then creating a flap for placement of the implant. That's the height of the gingiva immediately after that. So now we've taken the surgical guide that's resting on the adjacent teeth. This was fabricated from the wax up in the study model. And this is a thermal foil. And it has a hole that's drilled down the long axis of it to go ahead and accommodate the 2 millimeter guide drill. So this is the initial osteotomy with the 2 millimeter drill following the directions of the guide. And you can see where we are here at the crest of the bone. This is it with the guide in place. Relatively straightforward implant placement. This is an example of a drill with a stop, and you can see how that, we know we're at depth when we're down to the stop, and we're looking at that position between the teeth. This is the 2.5 finishing drill, so we went with a 2 millimeter, now a 2.5. And this is placement of the implant. Now, in this case, before we placed the implant, we did some cortical perforations over here because we're going to do a graft to build a root eminence here, because when the tooth was congenitally missing, that root formation didn't naturally occur, and so we want to go ahead and help it along. But we're fairly happy with the placement of that implant. We placed a graft. This is a demineralized bone matrix. Today, I would use a mineralized graft to go ahead and build this eminence. So this is an onlay graft. The implant is actually a native bone, but this is to build it up, protect the surface of the implant, and create an eminence of the root. We sutured this through with a couple of simple mattress sutures tied on the palate, and at this point then we went ahead and used a second vacuum form to go ahead and look for clearance. So we're going to temporize this implant at this point, so we want to do minimal preparation. Just enough to go ahead and get a temporary on. We don't want to do a final preparation of this abutment. Verify that clearance by looking again with our vacuum form at that point, and then starting to move on, and then creating our temporary. Okay, so here's our initial result. This is how the patient left. So we've corrected the gingival asymmetry, and we've replaced the congenitally missing tooth and built out the root eminence in that spot. And this is just a closer view looking at that temporary. This is a baseline radiograph, and indeed we certainly did have a very tight spot, and I think if you look carefully here, you'd say that there's at least 20 osteoblasts in between that implant and the root adjacent to it. But this is a very tight spot indeed in that, looking at that radiograph, which could be a little bit distorted. Here's a patient at 1 week. And we have very nice healing with these implants, nice tissue form around it. These are the sutures on the palate. And, modeling of the tissue with the temporary is certainly an advantage. At 2 weeks, this is our tooth in question. We have more maturation of the soft tissue. At 3 months, it continues to heal and form. And then this is a radiograph at 3 months, and then at 6 months, this is what we have with the temporary in place. Okay, so at 6 months post-op, we've now gone ahead and are moving on to the prosthetic phase, and we're doing shade selection. So this is conventional crown and bridge now because this is a one-piece implant. The abutment is prepared, and you can see that it's in line with the arch now, so that we're reasonably happy with the placement. We get a final impression, and then we go ahead and move this to the laboratory. Now, a couple of laboratory considerations that are important. One is that we need to pour these dies in epoxy because of the size of the abutments. These are very narrow, so you need something that's relatively strong. Second, that the preparation that is made on the abutment cannot be very deep margins. So it's going to have to be almost a feather edge not to over-prepare that. And that makes reading these margins rather difficult on the dies, and it also affects the crown selection. Originally, we thought we could go ahead and use all ceramic crowns, but because you need to have a relatively wide shoulder to support the porcelain, we moved, in this case, to crowns with a gold substructure, and that, the very thin, almost foil structure of the cap tank or AGC type crowns. So the gold structures give excellent color, and they give nice warm restorations, and so that you don't need deep margins on these. And then we use conventional crown and bridge alloys and bridges or splinted teeth. Okay, so here's the final restorations, and this is this patient now at 6 years, and doing quite well, and the characterization of the porcelain looks good compared to the adjacent teeth 6 years later at maintenance. This is just another example in the same project, same steps of 2mm drill, and then going ahead and placing the implant at that site. And again, this is implant placement, a graft to build up the root eminence. At this point, we created a little coping that was made of acrylic to capture the margins to make the temporary easier to make. And what this was, this acrylic prototype became eventually a comfort cap that was made by the manufacturer to go ahead and capture those margins. So with the acrylic in place, we could go ahead and pick that up and then finish that and produce a crown, and it greatly cut down on the amount of time that it took to finish the margins subgingivally. So here's this patient at 2 weeks, kind of the same thing, 3 months. Again, everything is looking like it's in good order and good form at that point, and then 6 months again, some good healing, and a final restoration looking at the 6-year follow-up. Again, this patient, has good form in the gingiva and the soft tissue, and we're pleased with that. Okay, other examples of where you could use these implants. A common problem is a patient that has, periodontally failing mandibular incisors. Using 2 of these implants and filling the voids around the implants when the teeth were taken out with freeze-dried allograft, and then placing an 18mm implant so that we can go below the height of the socket to go ahead and restore that. Coping's in place, going ahead now and picking that up with a thermofoil and reshaping it and making it temporary. So the patient came in with teeth, the teeth were extracted, left with a temporary in place, and was very happy. After a period of months, final impressions were made, and there's really no need for anti-rotation in these because of these will be splinted, and it's conventional crown and bridge from there. And that is the final restoration that was fabricated. Here's another example of congenitally missing lower lateral incisors. We said that was another common tooth that was lost. A patient in orthodontic treatment, the implants placed in those sites, temporaries put on the same day. 1 week later, already we have some nice soft tissue healing around these, and these seem to be an additional. Now, these implants are indicated for maxillary lateral incisors and mandibular incisor teeth. But also there are some situations, such as premolars, where you have a space clinically that is too large for one implant, but really not large enough for two conventional implants. For example, this space here, which is about 12 millimeters in diameter, if you tried to put two 4-millimeter implants in, keeping them 1.5 millimeters from each of the adjacent teeth, you'd only have 1 millimeter in between the implants, and you wouldn't be able to restore them. And this is a spot where you can think about using a 3-millimeter implant. This is a flapless surgery with a punch in two of these one-piece 3-millimeter implants, and then immediate temporization, again, putting the temporary in place. And there's the temporary as I left. In 2 weeks, we can already start to see the soft tissue starting to develop around this. And at 1 year, these have some nice gingival margins, and those held up for some period of time. Now, the implant placement in premolars, we're using a 3-millimeter or any narrow implant, needs to be slightly to the facial. You can't place it in the center line of the ridge because the implant is more narrow. So we need to think of it as if it was a pontic. And so we need to have this narrow so we can go ahead and have cleansability to the surface of the implant from the lingual or palatal side. So here are two 3-millimeter implants, and where the normal contour of the teeth may be here, we are going to go ahead and placing these in these narrow spots slightly to the facial so that we get better aesthetics from the buccal surface, and also looking at it so that we have cleansability. Okay, so the results from this study was that about 96% of the implants were successful at 6 years. One had functional mobility at 1 month. There was one that was lost there. There's no differences between flapped and flapless surgeries, grafted or immediate extractions, but the numbers were very small at this point, so that there were really no statistical differences. We measured radiographs over time, and we tried to look at what the bone loss was by looking at the time baseline, and then looking at over 6 and 12 months, and then out at 5 years. And we found that initially, during the first 6 months, we lost about 0.6 of a millimeter. So that was interesting, a little bit troubling at the time, but by 12 months we lost 0.7, and at 5 years we lost 0.75. Now, this may be related to the design of the implant. And if you look at it, remember we said that we placed the implant at this transition zone, and this is a machined metal margin where it's 1.5 millimeters and half of it is anodized. We placed it in between where the gold part met the silver part. And if we went back and did a re-entry and looked at it, we could see that where we placed it, there was remodeling of the bone down to the roughened surface. So the distance between where we placed the implant and where the roughened surface was is exactly 0.75 millimeters, almost identical to the amount of bone that we lost. The other thing we looked at was the Yenft index to go ahead and look at the loss of papillae, or the formation of papillae. And so if there's no papilla present, that's a Yenft index of 0. To refresh your memory, if it's up to almost half of the height of the crown to the contact, less than half is a Yenft index of 1. More than half is a Yenft index of 2. And if it completely fills the embrasure space, that's a Yenft index of 3. Okay, so here's the findings from this study. And we're very happy to see that 92% had completely filled the embrasure space with the papillae. So that was quite rewarding in that regard. Less with mandibular incisors and less with premolars. About 60% for mandibular incisor, and about 2/3 of the premolars filled the embrasure space. Now, part of that is a bias in the study because the maxillary lateral incisors tended to be younger post-orthodontic patients, and that could have had an influence in that regard.